Welcome to the Radonc Smart Review Head and Neck Cancer series.
It is great to be back.
We are diving into episode 29 today, Advanced Larynx T4a and the Unpreservable.
This is a really crucial topic. I think in episode 28, we spent a lot of time on the success stories.
We did.
We looked at when organ preservation works, beautifully. We covered the VA larynx trial, which showed it was even possible.
Right, and then RTOG 9111, which really established concurrent chemo-RT as the standard of care.
Exactly.
And the big takeaway from all of that was that for the right patient, preservation can offer really excellent outcomes. You get to keep the voice, you avoid a stoma, and you cure the cancer.
Ideally.
Ideally, yes.
That's the key word. But here's the thing, and this is really the crux of our whole discussion today. Not every patient is the right patient.
That's the pivot. Today is all about the flip side of that coin. This is about knowing when not to pursue preservation.
And maybe more importantly, why. It's about recognizing those specific patients we're trying to keep the larynx is, well, it's either totally unrealistic or, frankly, worse for them.
Worse? How so?
Worse, because it might be actively harmful to their oncologic outcomes.
Yeah.
And this matters so much because the reflex, for us as physicians, and definitely for patients, is to preserve.
Of course. That impulse is incredibly strong.
It is. Patients want to keep their voice. We want to help them do that. It feels like a win.
It does. But if we take the logic from RTOG 9111 and just apply it to patients who were never actually in that trial,
we're setting them up for failure. And we have to be really, really clear about what failure means in this context.
Right.
Salvage surgery after failed chemoradiation is just. It's significantly harder, it comes with way more complications, and the functional outcomes are often much worse.
So by the end of this, our goal is to give you a clear framework. We want you to be able to identify that unpreservable patient.
And to understand why those landmark trials just don't generalize to, bulky T4a disease.
And finally, how to counsel patients. How to guide them toward preservation when it's right, but also toward an upfront laryngectomy when that's actually the better, safer path.
That counseling piece is absolutely critical.
So let's start with the case. We're going to put you in the hot seat right now.
Let's do it.
Okay, so picture this patient walking into your clinic. A 58-year-old man. He's got a 50-pack year smoking history. And here's a key detail. He's still smoking.
Still smoking a pack a day.
A pack a day right now.
Okay, so that's a major red flag already. Just on outcomes alone. And let's pause on that 50-pack year number. We kind of gloss over that, but physiologically what that means is his vasculature is compromised, his mucociliary clearance is shot.
And he probably has significant field cancerization.
Exactly. And the fact that he's still smoking, it suggests a high-grade addiction and, potential compliance issues with what's going to be a brutal treatment course. But, okay, go on.
He presents with 4 months of progressive hoarseness. At this point, he's nearly aphonic. He can barely make a sound.
Okay.
He reports dysphagia to solids. He's lost 15 pounds. He denies any stridor, but he does admit to occasional aspiration episodes when he's drinking liquids.
All right, so functionally, he's already in trouble. That aspiration is a key detail. It tells us the glottic valve mechanism is failing. He just can't protect his airway.
Exactly. So let's get to the exam. You do a flexible nasopharyngeal endoscopy, an NPL. You see a large, bulky, transglottic mass.
And when we say transglottic, let's just visualize that for a second. This isn't just a tumor sitting on one vocal cord.
No.
It has bridged the gap. It's crossed the laryngeal ventricle. It's linking the false cord above to the true cord below, and it's probably diving down into the subglottis. It has vertical height. It is a massive tumor.
That's a great visual. On the exam, it involves the right true cord, the false cord, and the arytenoid. The right cord is fixed.
Okay, fixation. That implies deep invasion. It means the tumor has either invaded the thyroarytenoid muscle so profoundly it can't contract, or it's frozen the cricoarytenoid joint itself. That's significant.
It is. And there's extension to the anterior commissure and into the subglottic region.
Wow.
Now for imaging, CT next shows the tumor is eroding through the thyroid cartilage.
Erode, okay.
And there's a 1.5 centimeter soft tissue mass that's extending out into the strap muscles.
The definite extralaryngeal spread.
Definite. There's also sclerosis of the cricoid cartilage, but no definite erosion there. And he has bilateral level 2 to 3 adenopathy, a 3 centimeter right node, and a 2 centimeter left node.
I would say so N2C.
Right. We get a PET CT, and it confirms FDG avidity in the primary and the bilateral nodes. No distant mets.
Good.
Biopsy comes back poorly differentiated squamous cell carcinoma. So, to summarize the staging, this is a T4a N2C glottic SCC.
A very clear but very concerning clinical picture.
So here's the consult question for you, the listener. Is this patient a candidate for organ preservation?
And just pause for a moment. Think about it. Is he?
This is exactly the kind of case that trips people up on boards. And, more importantly, in real life, this is where a clinical decision has massive consequences.
Absolutely. If you treat this the wrong way, you aren't just risking a recurrence, you're risking a catastrophic failure of the entire airway and swallowing mechanism.
It's a classic trap.
It is. And to answer it correctly, you need a system. You need a framework to work through it, so you aren't just, guessing or going with a gut feeling.
So let's introduce that framework. We call this the Unpreservable 4-step algorithm.
And this is really the spine of our whole episode today. If you take nothing else away, just remember these 4 questions. Every piece of data we're about to discuss basically just answers one of them.
Okay, step 1, is it resectable?
This is the very first gate. You have to differentiate T4a from T4b. If you see T4b features, so we're talking invasion of the prevertebral space, encasement of the carotid artery, or involvement of mediastinal structures, then the tumor is unresectable.
And if it's unresectable, that's a totally different conversation.
Completely different. That's a conversation about palliative goals, or maybe induction chemo to see if you can get a response. But it's not the standard preservation versus surgery debate. Surgery isn't even on the table.
Right. So for our case,
our patient has no prevertebral involvement, no carotid encasement. It's T4a. It is resectable. So he passes step 1.
Okay. Step 2. Is the larynx functional today?
This is huge. You have to assess the baseline function. Can the patient swallow? Can they breathe? Are they already on a track or a PEG tube? Do they aspirate?
But why is that so critical? I mean, the larynx is still there anatomically.
Because we have to separate anatomical preservation from functional preservation. If the larynx isn't working now, if it's just a tube of cartilage that lets food fall into the lungs and doesn't make sound, what exactly are you preserving?
You're preserving a liability.
You're preserving a non-functional organ. A liability, exactly.
We'll apply it to our case.
He's nearly aphonic. He has significant dysphagia. He's having aspiration episodes with liquids. His baseline function is already severely impaired.
So that's a big strike against preservation. Okay, step 3. Is the framework destroyed or grossly transgressed?
And we need to define that high-risk territory. When you have through-and-through cartilage penetration plus extralaryngeal disease, you're looking at a totally different biology than, say, a small T2.
And this is where the trial data gets a little tricky, isn't it?
Oh, very tricky. We'll dive deep into this, but the RTOG 9111 eligibility criteria actually excluded patients with bulky framework transgressing disease. So this exact presentation was underrepresented in the trial that set our standard of care.
So for our case patient,
the tumor is through the thyroid cartilage. There's a 1.5 centimeter soft tissue mass in the strap muscles. This is gross framework transgression. The castle walls have been breached.
Another strike. All right, finally, step 4. Can the patient realistically complete definitive CRT well?
This is the practical reality check. Can they tolerate cisplatin? What's
Yeah.
their support system like? Can they get to their appointments every day? Are they going to be compliant? And critically, what is their smoking status?
And our patient.
Still smoking a pack a day. And we know from the data from Beitler and others that persistent smokers just have significantly worse outcomes with preservation strategies.
Let's unpack that for a second. Why does smoking during radiation matter so much?
It's mechanistic. The carbon monoxide from the smoke binds to hemoglobin way better than oxygen does. It forms carboxyhemoglobin.
And that reduces oxygen in the blood.
Right. Basically reduces the oxygen carrying capacity. And radiation therapy, as we know, it relies on oxygen-free radicals to kill cancer cells. If the tumor is hypoxic because the patient is smoking, the radiation is less effective. You are literally protecting the tumor by smoking.
So when you put it all together and walk through this algorithm, our patient fails multiple steps.
He does. His baseline function is poor. His framework is grossly transgressed. He's a persistent smoker. This is not a preservation candidate.
It seems so clear when you lay it out like that, but to really own this decision, you need the evidence base. You need the numbers.
Absolutely. You need the numbers to defend your plan, both on your boards and to the patient.
Okay, before we get into the heavy data, let's just anchor this with some board pearls. High-yield takeaways you need to have locked in.
Let's do it.
Pearl 1. The definition of T4a versus T4b.
Simple but vital. T4a. through the thyroid cartilage or into tissues beyond the larynx, trachea, strap muscles, etc. It's moderately advanced, but resectable. P4B, prevertebral space, carotid encasement, mediastinal structures. It's very advanced and unresectable.
Pearl 2. Imaging interpretation.
This is a classic board trap. Cartilage sclerosis does not equal invasion.
Is that a go?
Cartilage sclerosis does not equal invasion. It can be inflammatory. It can be reactive. You need to look for erosion, lysis, or ideally, a through-and-through penetration with an extralaryngeal mass.
Pearl 3. The VA larynx stats on T4s.
In the VA larynx trial, the salvage laryngectomy rate for T4 patients was 56%. 56. Compare that to T2 and T3 patients, where it was only 25 to 29%.
Wow. Pearl 4. The MDACC data on function.
This is the sobering one. The data from Rosenthal showed functional impairment is super common, even if survival looks the same. The key line is, preserved does not equal functional.
Pearl 5. The Beitler framework.
This just helps you identify poor candidates. Beitler says poor candidates are those with a poor prospect of function, persistent smokers, extensive framework destruction, and lack of support. Our patient.
And Pearl 6. The reality of salvage surgery.
It is not a free pass. It has about a 38% complication rate. And importantly, those complications predict worse overall survival.
Okay, great summary. Now let's go deeper on staging because this is where the whole decision tree starts. T4a versus T4b.
Right, so T4a is moderately advanced, resectable. The definition hinges on the tumor invading through the outer cortex of the thyroid cartilage or are invading tissues beyond the larynx.
And just to be specific, what tissues count for that?
The trachea, the soft tissues of the neck like the strap muscles, the thyroid gland, the esophagus.
And you said the key word there is through.
Through, that's the operative word. If the tumor is just, abutting the cartilage or causing some sclerosis inside, that's not necessarily T4a. It has to penetrate through.
And T4b, just to contrast.
T4b is very advanced, unresectable. That's the prevertebral space, carotid encasement, or mediastinal structures.
And the management is completely different.
Completely. You can't safely resect those tumors.
Okay, let's talk about the cartilage nuance. You called this a board trap.
It really is. The problem is that cartilage involvement isn't binary. It's not just yes or no. There's a whole spectrum. Minor inner cortex involvement has actually been staged differently across various editions of the AJCC manual.
Which has to make looking at old data really difficult.
Oh, it makes it incredibly messy. The Rosenthal series from MDACC explicitly notes these reclassification issues. So you could be looking at different patient populations depending on the year the study was done.
So what's the rule for the boards? What do we need to know now?
For boards, focus on the undeniable stuff. Focus on through-and-through penetration. Focus on extralaryngeal soft tissue extension. Those are the definitive T4 features. Don't get hung up on some minor inner cortex sclerosis.
That leads perfectly into imaging interpretation. How do we avoid overcalling this on a CT scan?
You have to know the pitfalls.
Yeah.
And the biggest one is the sclerosis trap.
So let's really dig into what that white line on the CT actually is. If it's not tumor, what's happening?
So think of the thyroid cartilage as a classal wall. When the tumor camps right outside the gate, the defenders inside start reinforcing it. The tumor proximity triggers this whole inflammatory cascade. Cytokines get released.
And that stimulates the bone cells.
Exactly. It stimulates the osteoblasts within the calcified cartilage, and they start laying down more calcium to try and wall off the threat. On a CT scan, that dense calcium lights up bright white. That's sclerosis.
So it tells you the tumor is near, but not necessarily in.
Precisely. It's a reactive change, not necessarily an invasive one.
So if sclerosis is the wall being reinforced, what does actual invasion look like on the scan?
Invasion looks like the wall being breached. You look for lysis or erosion. That's where the tumor is actually destroying the cartilage. So instead of bright white, you see a jagged gap, like a black hole in the cartilage where the tumor is eaten through.
And a most reliable sign of all.
Definite extralaryngeal tumor. If you see a soft tissue mass in the strap muscles that is clearly contiguous with the primary, that is T4a, there is zero ambiguity. The enemy is in the courtyard.
What about MRI? Is that better for this?
It can be. MRI has better soft tissue contrast, which can help when the CT is equivocal, but you have to be really careful not to overinterpret the T2 signal.
Why? What's the pitfall there?
Edema. Just like sclerosis is a reaction, edema is a reaction. Inflammation causes water content to go up. Water is bright on T2. Tumor is also bright on T2. So you look at the cartilage and it's bright. Is that tumor or is it just reactive edema? It's very, very hard to tell.
So the rule of thumb is just be cautious.
Yes. If you're shown an image with only sclerosis, don't call it T4a. Describe it as concerning for involvement, but don't change your entire treatment plan from preservation to laryngectomy based on sclerosis alone.
Okay, that is a critical distinction. Now let's move to the evidence. We said the standard of care for many patients is preservation, based on VA larynx and RTOG 9111. But you said that logic fails for T4a, so why?
Let's start with VA larynx. That's the study from the early 90s that really put this whole idea on the map. The goal was just, can we avoid total laryngectomy?
Right, it was just a feasibility question.
Exactly. And the headline result was, yes, you can. Overall, 36% of patients in the preservation arm needed a laryngectomy, which sounds pretty good.
Yeah, a proponent would say, look, 64% kept their larynx.
You would. But when you break that number down by T stage, the story changes completely. For T2 and T3 patients, it was about 25 to 29% who needed salvage surgery.
Okay, about a quarter. Seems reasonable.
Right. But for the T4 patients, 56%.
56%.
More than half. More than half of the T4 patients who tried preservation ended up needing surgery anyway. And remember that salvage surgery was harder with more complications.
So VA larynx basically proved that while preservation is possible for T4, it fails the majority of the time.
Correct. And that experience directly informed the design of the next big trial, RTOG 9111. The investigators knew that big T4s often failed preservation. So what do?
They excluded them.
They excluded them.
I want to make sure I heard that right. The trial we used to justify chemoradiation for larynx cancer excluded the big T4 patients.
Yes. The eligibility criteria for RTOG 9111 specifically excluded greater than 1 centimeter base of tongue invasion. And crucially, it excluded penetration through the thyroid cartilage.
So the exact patient we're talking about today with through-and-through cartilage penetration, he wasn't even allowed in the trial that defines our standard of care.
Exactly right. It was deliberate. 9111 was designed to test preservation in a population where it had a reasonable chance of working. They didn't want to dilute the results with patients they knew would likely fail.
That changes everything about how we quote that data to patients.
It really does. The result was that only about 10% of the participants in 9111 were T4 at all, and they were the limited favorable T4s. They were not the bulky cartilage-destroying tumors we see in clinic every day.
So here's the board-safe statement. Bulky framework transgressing disease was underrepresented in RTOG 9111, so preservation outcomes from that trial don't generalize cleanly to classic T4a.
That is the perfect way to say it. When you quote that 82% larynx preservation figure, you have to remember who was in that trial. Applying it to our case patient is just inappropriate.
Okay, so if the big randomized trials excluded these patients, what data do we have? We have to look at real-world retrospective data.
We do. And the MBACC series from Rosenthal in 2015 is one of the best data sets we have on this. They looked at 221 patients with T for larynx SCC.
And what did they find on survival?
Well, interestingly, survival looks similar. Median survival was around 64 months in both groups, the laryngectomy group and the preservation group.
I have to play devil's advocate here. If survival is the same and I'm the patient, you tell me I have the same chance of living whether I lose my voice box or keep it. I'm going to choose to keep it. Why is that the wrong instinct?
That is the intuitive leap, and it's exactly the trap. Because survival is just a binary metric, dead or alive. It doesn't capture the quality of that survival. You have to look at the functional outcome.
All right, hit us with the numbers on function.
They looked at disease-free survival with a fully functioning larynx. So no tube, no track, talking, eating. At 5 years in the preservation group, it was 32%.
That's already pretty low.
It gets lower. At 10 years, disease-free survival with a fully functioning larynx was 13%.
13. 1-3.
1-3. Let that sink in. At 10 years, only 13% of T4 patients who went for preservation had a functioning larynx and were disease-free.
So what happened to the other 87%?
They either died, had a recurrence, or, and this is the key part, they had a preserved larynx that was non-functional.
Let's define that. What does preserved but non-functional actually look like for a patient?
It's miserable. Imagine you technically still have that cartilage box in your neck, but the vocal cords are frozen. You can't speak above a whisper. Or worse, the mechanism is incompetent. Every time you swallow your own saliva, it trickles down into your trachea. You're coughing constantly, getting recurrent aspiration pneumonias.
So they can't eat.
They are PEG dependent. a tube in their stomach because they can't eat by mouth.
In their airway.
They might be tracheostomy dependent because the airway is scarred down, or stenotic, so they end up with a tube in their neck anyway. They have a tube in their stomach, a tube in their neck, they can't talk, they can't eat. But on paper, they preserve their larynx.
That is horrifying. That is not a treatment success.
It is absolutely not a success. It's an organ that's physically present, but physiologically a liability. It's a source of infection and suffering.
So the anchor line here is, keeping the larynx is not the same as keeping function.
Precisely.
And there's also the NCDB data from Grover.
Yes. They looked at about 1,000 T4a patients. They found that total laryngectomy patients had a median survival of 61 months versus 39 months for the organ preservation patients.
That's a huge difference.
It is, but we have to be careful. The selection bias is massive. The sicker patients often get preservation because they can't handle the surgery, but it still adds to the overall picture.
Right. But just to be balanced, there is a counterpoint. Not everyone agrees that all T4As need surgery.
No, absolutely not. And Beetler published an important counterpoint in 2018. Their argument is that with modern techniques, IMRT, better supportive care, that survival gap is narrowing.
But even Beetler has a selection framework. He's not saying preserve everyone.
Not at all, and this is the key. They endorse the belief that patients with little prospect of regaining laryngeal function are poor candidates for preservation.
And who does that include?
Patients with extensive destruction of the laryngeal framework. And importantly, patients who are persistent smokers.
So even the pro-preservation side agrees. If you have extensive destruction, poor function, and you're a smoker, you should probably have a laryngectomy.
Exactly. Which brings us right back to our case patient.
It does. Let's drill down on this functional larynx distinction. You said preserved does not equal functional. I feel like this is the concept that really needs to click.
It's everything. We talk about larynx preservation rates like it's a simple success metric. But clinically, it's not enough.
And beyond the medical issues, the PEG, the track, what's the social impact?
It's profoundly isolating.
Yeah.
Eating is social. If you can't eat, you stop going out. If you're coughing constantly, you withdraw. The quality of life for these patients can be worse than for laryngectomy patients.
Because with a laryngectomy, at least the aspiration problem is solved structurally.
Exactly. The airway and the foodway are completely separated. They can eat. And with a TPA tracheoesophageal puncture, they can often learn to speak surprisingly well. They can get back to a life.
So, board pearl. If a patient ends up with a preserved larynx but is PEG dependent and aspirating, we have not helped them.
That's right.
Okay, let's crystallize this. Who should not pursue preservation? Let's list the hard exclusions, the board-safe ones.
Number 1, greater than 1 centimeter base of tongue invasion. That's a specific RTOG 9111 exclusion.
Number 2,
Through and through thyroid cartilage penetration with an extralaryngeal mass, your classic bulky T4a.
3,
Non-functional larynx at baseline. If they can't swallow or breathe now, there's nothing functional to preserve.
and 4.
T4b features. Unresectable.
Now, what about the strong considerations, the things that should push you hard towards surgery?
First, the persistent smoker. We know they get worse. Poor support or anticipated poor compliance. CRT is a marathon. If they can't complete it, that's a failure. Surgery is, in some ways, one and done for the primary.
Third.
Extensive framework destruction, even if it's not quite through and through.
Fourth.
Airway compromise that requires an emergent track that just screams bulky disease.
And finally, tumor volume.
Yes, there's a useful heuristic from the University of Florida. For glottic tumors, if the volume is over about 3.5 to 4 cc's, local control starts to drop. For supraglottic, it's more like 6 to 8 cc. It just helps you think, is this thing too big to melt away and leave a working organ?
Okay, let's talk about the backup plan. We often hear, well, we can try chemoradiation, and if it fails, we can just do surgery then.
That is probably the most dangerous sentence in this entire discussion.
Why? Tell us about the reality of salvage laryngectomy.
It comes down to tissue biology. In a primary surgery, the tissue planes are clean, the blood supply is great, but after 70 grays of radiation, it's a nightmare. The tissues are fibrotic, a woody neck, the blood vessels are sclerosed, so when you cut that tissue, it doesn't heal, it dies.
We have data on this, that MDACC series from Book of Valas.
Yes, they looked at over 300 patients. The postoperative complication rate was 38%.
Let's talk about the pharyngocutaneous fistula, the PC fistula. What is that?
It's when the closure of the throat breaks down. Saliva leaks out of the pharynx, through the neck tissues, and out onto the skin. It's devastating. It adds weeks to the hospital stay and often requires another big surgery to patch the hole.
And this happens way more often in salvage settings.
Way more often. Then you have pharyngeal stenosis, where the throat scars down so tight they can't swallow, wound breakdown,
Oh.
and catastrophically carotid exposure and blowout.
And these complications actually affect survival.
They do. Post-op complications independently predict shorter overall survival.
So the teaching point is, do not assume salvage surgery will be straightforward.
Right. It's not a risk-free backup plan. It is a high-stakes rescue mission.
Which brings us to the most important part, patient counseling.
Yes, the rubber meets the road here.
So I want to give our listeners the actual words to use. Let's do two scenarios. Scenario A, the reasonable preservation candidate.
Okay, so this is the T for a patient who actually IS, a good candidate. Good baseline function, not grossly destroyed, committed to quitting smoking.
How do you talk to them?
I'd say something like, based on your tumor and your health, chemoradiation is a reasonable option. Gives you a chance to keep your voice box. But I need to be really honest about what the data show. In the long run, survival is similar whether we do surgery or chemoradiation first, but the functional outcomes are different.
And then you tell them the numbers.
Even when preservation works, many patients end up with swallowing problems or voice changes. At 10 years, in one large study, only about 1 in 10 patients who tried preservation ended up with a fully functioning larynx. That doesn't mean the rest all died. It just means they had recurrences or a larynx that just didn't work well.
And the risk of failure.
If we go this route and it doesn't work, we would still offer surgery. But that surgery is more difficult after radiation, there are more complications, and it takes longer to recover.
And the closing question.
So the question for you is, what matters most to you? Is it the chance to keep your natural voice, even knowing all these risks? Or would you rather we go with the surest path to cure, even if it means losing your larynx? I can support you either way, but I want you to make this decision with your eyes open.
That's powerful. It's balanced. It's honest.
Right.
Now, scenario B, our patient from the beginning. Growth spread, impaired function, smoker. How do you tell him he needs surgery?
This is a harder conversation, but you have to be direct. I know that hearing you might lose your voice box is a difficult thing. I wish I could offer an easier path. But based on everything I see, your tumor has grown through the cartilage, your swallowing is already impaired. I believe planned surgery up front gives you the best chance of a cure with the best quality of life.
And you explain the why.
Here's why I'm saying this. The big trials that showed chemoradiation can work didn't include patients with tumors like yours. They specifically excluded them because they knew the failure rates were high.
And the functional aspect.
And when we look at patients like you who did try preservation, even if they kept the larynx, very few of them had one that worked well long term. Only about 1 in 10.
And the salvage risk.
And if we try this and it fails, the salvage surgery is much harder. The complication rate is about 4 in 10.
And how do you close that?
I'm not trying to take away hope. I'm trying to give you the best chance of being alive and well in 5 years. And for you, I believe that's surgery first. We have excellent speech therapists and rehab. Many patients learn to communicate well after this surgery. This is your decision. But I wanted you to have the full picture.
And for both, you end with, take some time, talk to your family.
Always. Let them process.
A quick word on T4b before we wrap up. Unresectable. What's the workflow?
The practice is often to use induction chemotherapy to see if they respond. If they get a good response, you might consider definitive CRT. If they have a poor response, it becomes a goals of care conversation.
So establish goals of care first.
Before offering any treatment, yes.
Okay, let's bring it all back to our case. The 58-year-old smoker.
Step 1, resectable. Yes. No T4b features.
Step 2, functional.
Impaired. Aspiration dysphagia.
Step 3, framework.
Grossly transgressed. Through the cartilage with an extralaryngeal mass.
Step 4, can he complete CRT well?
Very concerning. He's still smoking.
So the recommendation is?
Up front, total laryngectomy with bilateral neck dissection, followed by adjuvant therapy.
And adjuvant will depend on the path.
Correct. Positive margins, or ENE, he gets chemo-RT. Other high-risk features, you consider RT alone versus chemo-RT.
All right, board blitz. 3 questions. You ready?
Ready?
Question 1. 60-year-old T4a extralaryngeal spread into the strap muscles. He has a functional larynx. What's the recommendation?
C, total laryngectomy followed by adjuvant therapy.
Why?
Through and through, penetration with extralaryngeal spread was essentially excluded from RTOG 9111. The board-safe answer is upfront laryngectomy.
Question 2. In the VA larynx trial, what percentage of T4 patients treated with induction chemo then RT ultimately required salvage laryngectomy?
C, 56%.
Rationale.
VA larynx showed 56% of T4s needed salvage, compared to about 25% for T2 and T3. This high failure rate is why 9111 excluded them.
Last one. Question 3. The MDACCT4 retrospective showed that at 10 years, what percentage of patients who tried preservation had disease-free survival with a fully functioning larynx?
B, 13%.
And the key takeaway.
Preserved does not equal functional. The 5-year rate was 32%, but it dropped all the way to 13% by 10 years.
All right, let's wrap this up. What is the big final takeaway?
The big takeaway is that not every patient should pursue organ preservation. We have to move past the reflex to save the voice, if it means compromising the cure or leaving the patient with a non-functional organ.
Use the 4-step algorithm.
1, resectable. 2, functional. 3, framework transgressed. 4, compliance and smoking.
Remember the staging nuance?
Sclerosis is not invasion.
Remember the trial limits.
RTOG 9111 excluded the bulky stuff.
Remember function.
13% fully functional at 10 years.
And remember the cost of failure.
38% complication rate for salvage surgery.
This was a heavy but very necessary episode. Next time in episode 29B, we are getting technical. We're covering locally advanced larynx planning.
We'll talk target volumes, nodal coverage, post-laryngectomy RT, stoma coverage, and all the late effects. It'll be a good one.
Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next episode. Thanks for tuning in.